Welcome back, everybody. Hope you had a nice break. What an amazing morning that was. And we're going to keep things going. I wanted to introduce Dr. Megan Mio, who's going to chair our afternoon session. So Megan is a postdoctoral fellow here at the Center for Youth Bipolar Disorder and has spent the last 4.5 years becoming a leading expert internationally on retinal vessels in the eye as it relates to bipolar disorder. And so we're thrilled that she's had a role with other groups in other countries and trying to disseminate that type of research. So if you're interested, let us know. But without further ado, Dr. Mio.
Thank you to Ben for the introduction. I'm happy to be chairing this afternoon session. We're following up on a morning of really excellent keynote speakers. So our first speaker this afternoon is Dr. Danella Hafeman. She's an assistant professor of psychiatry at the University of Pittsburgh, and she earned her medical degree as well as a PhD in epidemiology at Columbia University. She then completed her psychiatry residency and a child psychiatry fellowship at the University of Pittsburgh Medical Center. Dr. Hafeman's research, which is supported primarily by the National Institutes of Mental Health and a NARSAD Young Investigator Award, focuses on youth with and at risk for bipolar disorder. And her research also focuses on understanding clinical and neural mechanisms of risk and resilience in these youth, with the ultimate goal of preventing progression of mood disorders in this vulnerable population. Clinically, she works as a child psychiatrist in the Child and Adolescent Bipolar Services Clinic, where she evaluates and treats youth with and at risk for bipolar disorder. So welcome up, Dr. Hafeman.
Oh, thank you, everybody, for being here. Thanks so much, Dr. Goldstein, for organizing this. It's really such a pleasure to be here with everyone. So today I'm going to present on some pretty new findings, actually, from my NARSAD award that just finished. So I'm very excited about these findings. They're also very new. So this is some of the first time that I'm talking about it. But looking at longitudinal stability of resting state target networks in youth with bipolar disorder. And I should say NIMH and NARSAD funding, no commercial disclosures. All right, so I come at this from the standpoint of a psychiatrist, very interested in how we can make our clinical measures and neuroimaging measures relevant on the person level. And so the rationale for this work actually built from some findings that have been emerging in the last few years in an exciting field of precision imaging. So a lot of this has been out of Washington University. And basically what these studies have shown is that if you have enough data, so 20 minutes-ish of resting state data on somebody, that they have a lot of stability of network measures over time, at least in healthy individuals. So the idea that that was really kind of the basis for the NARSAD in this talk today is that we know that bipolar disorder is characterized by fluctuations in mood and energy. So the question is, could this instability be mirrored or maybe perhaps even caused by instability of relevant networks? So another piece of work that this research built on was several cross-sectional studies in adults that have started to identify possible markers of mood state in adults, but they're, just one time, how do manic people look versus more depressed people? So it turns out that mania is associated with increased functional connectivity in reward circuitry, at least in these studies, and that it is also associated with more kind of spontaneous activity in networks like the frontal parietal network, sensory motor network, which are really involved in kind of planning and doing, and then more spontaneous activity in the default mode network, which Manpreet talked about earlier today with depression, which is really involved in more self-related processing and rumination. So that led to the hypotheses from this grant, which were, could we look at these particular networks that may be fluctuating with mood and look at them across time in individuals with bipolar disorder to try to see if they showed more instability in these networks than healthy controls. And so the kind of first set of hypotheses were around this intrinsic functional connectivity of the reward network. And you will see many kind of familiar regions here because Manpreet talked about these earlier, including the thalamus, but really, connectivity between that ventral striatum, some other subcortical regions, and then ventromedial prefrontal cortex. The other kind of set of hypotheses were around ALFF. So amplitude of low frequency fluctuation is one way of sort of measuring spontaneous activity of networks. So based on those findings that I just talked about, what we wanted to see is if sort of default mode, functional or frontal parietal network and sensory motor network were fluctuating across time in individuals with bipolar disorder. So it's a pretty small study because they're very intensively sampled. There's 10 individuals, we recruited 10 individuals with bipolar disorder, and they did have bipolar 1 or 2. They were all transitional age between the ages of 17 and 23, and they were scanned 4 to 6 times over 9 months. We followed them weekly with mood questionnaires to try to scan them in different mood states to really see if we could capture that instability. We compare this with 4 healthy controls, there will be 5, who were also scanned 4 times, also over a period of 9 months. The scanning protocol is important because it wasn't just like a 6-minute resting state scan where it would be challenging to sort of have that, stability in healthy controls. So what we did instead was 20 minutes of resting state. Now, staring at a fixation cross for that long, it's very challenging. So we used something called Inscapes, which is a sort of non-engaging video that really activates similar networks to rest. We also collected Forrest Gump and Reward, but that we've not analyzed those yet. So we did pre-processing of the data to remove things like motion artifact. And then we essentially extracted the time series and ALFF from what's called the Shen parcellation. So for those of you not familiar, a parcellation essentially breaks up the brain into, in this case, 268 parcels based on having similar activity and similar connectivity patterns. It's a way of reducing the brain to something a little bit more manageable. And then we calculated functional connectivity based on the correlation of those time series. So this slide sort of shows that in a pictorial fashion. So that's the Shen parcellation right there with the 268 parcels. So we extracted the time series for each parcel and then calculated a correlation matrix, which I'm going to show you what that looks like in a minute. We also extracted the average ALFF for each parcel. So we had like 268 parcels that had their average ALFF. We did this for the whole brain to sort of see what we would find. But again, our main hypotheses were really about reward circuitry and functional connectivity and ALFF. And the ALFF, we just use the Shen networks. So the frontal parietal, default mode, and sensory motor. Okay, so then for each session, what you get is this functional connectivity matrix, right? So these are how the different parcels are correlated. So you can really see the brain has networks, so different parcels are much more correlated than others. And then, what you can do for each scan or session, you can just look at the upper triangle because it's symmetric, and then you can linearize this. Now you have like just a string of numbers, and you can say how correlated is one scan to the next scan. So it's actually a fairly simple analysis after you've done all the pre-processing and fancy stuff. Now for the ALFF, it's even simpler. You have 268 measures of ALFF. You're basically looking at how similar people are over time. So here is our whole brain analysis. So on the left, you can see the functional connectivity. This is for the entire brain. Now, and the bipolar disorder participants are on the bottom, the healthy controls are on top. Now, I didn't do anything special to make these boxes come out, except that I put all the sessions for a given subject together. So you can see that the within subject correlation of these measures is much higher than the between subjects. So there really is that stability. And this doesn't really need a p-value. It's just very obvious, but it is less than 0.001. For ALFF, you get a very similar picture. Now it looks like they're less correlated because it's blue, but just notice that the ALFF is super highly correlated. So you can't see anything if you look at the entire spectrum of correlations. And so again, you can see the within person. So again, each of these boxes is just a session correlation, either between people or within people. Okay, so how about our primary analyses, which were based on the reward and other networks. So functional connectivity for reward circuitry. Now we're just looking at those nodes that are those parcels that are nodes in the reward network. Okay, so there's 18 of them. You can see that overall, the structure kind of disappears, but more for the bipolar disorder than the healthy controls. So if you look at the healthy controls, there's still sort of, boxes that you can make out that are really sort of the more within person stability than between person. With the bipolar disorder, that essentially goes away. On the right, what we did was just map it by subject, actually. So those are 10 different subjects with bipolar disorder, and then 4 healthy controls. The 10 subjects with bipolar disorder, the individual dots are the session pairs. So, session 1 with session 2, session 1 with session 3, etc. The lines are the average. If you just look at the lines across subjects, they are overall lower in the bipolar disorder group than the healthy controls, as we hypothesized. And so we did that. We assessed that statistically a few different ways. So we did it on the sort of session pair level. I won't go into the details of this, but essentially nesting within session and subjects breaks frequentist models. So we used Bayesian modeling to look at this. So bipolar sessions had a 0.12 lower correlation on average than healthy controls. And the 95% prediction interval didn't cross 1, so that means it's significant, although you're not really supposed to say that in Bayesian analyses. Subject level analyses showed essentially the same thing. And so again, confidence interval didn't cross 1. This is almost perfect classification. I mean, it's a super small sample, and I'll probably say that many more times, but it's almost perfect classification. So the AUC here is 0.925. So for ALFF, we actually saw something similar. So again, just to walk you through, here you can see the kind of subject level structure, but the individuals with bipolar disorder have, so I don't know if you can actually see this, they have a little bit more of a red tint than the individuals, or the healthy controls have a little bit more of a red tint than the individuals with bipolar disorder. And so when we kind of map it out in the same way that we did functional connectivity, we see that, again, most of the individuals with bipolar disorder, with a few exceptions, are showing lower stability over time in these measures than the healthy controls. And again, this is significant in Bayesian models and individual models, subject level, and the AUC is actually also 0.925. It's not a typo. Okay, so how about when you kind of put them together? Well, we can't really do that because it's a pretty small sample. So making many statistical, sort of conclusions about that would not be correct. But I wanted to show this one thing because I think it's very interesting for future work. So session level, the ALFF plus functional connectivity put in the same model explains 74% of the variance. But really, I think the more important thing and more interesting thing here is this negative correlation that you see between functional connectivity on the x-axis and ALFF on the y-axis. And again, this is stability of functional connectivity in ALFF within those with bipolar disorder. So why would you see that? Well, one possibility, and this actually brings me back to my epidemiology days, there is a form of selection bias where if you select a certain group of people, you can create a negative association between two causes of that thing. So the way that I've always understood it best is if the grass is wet and you know it rained, then it's less likely that the sprinklers were on. So I'm not saying this is the case here because it will require more, but it's the possibility that these are actually two different causes, correlates of bipolar disorder that could map on to different features. Again, super preliminary, but I think, at least for me, very interesting. All right, so we've given it a name. for a future grant application, which is within person network instability, or with me. So this may be a person level marker of bipolar disorder versus healthy controls. And the caveat, which I could say 100 times, it's a small sample, particularly the controls. We are getting one more and may end up getting a few more, just to sort of, if reviewers ask us to. And so a lot of future directions though. So our individuals with bipolar disorder, they were selected to be symptomatic. So they had at least one manic or hypomanic and one depressive episode over the last year. And then we scanned them when they were symptomatic. So the question is, will we see this in less symptomatic bipolar disorder? Another interesting question is whether this is found in bipolar disorder only, or also in other disorders like major depressive disorder, which would have a lot of connotations in terms of whether it could actually be useful someday as a test. And then finally, that sort of negative correlation points to this interesting question of whether these markers might map on to things like symptom course, sleep, response to medication. There's a lot of there's so much heterogeneity within bipolar disorder, and could some of that be related to sort of the severity of these markers? So I have no idea how I'm doing on time, but I'm finished. So thanks everyone for listening. Oh, except for the most important part, I have to say that this was a very intensive study, and the patients who participated in this were amazing. Like, they really did fill out almost all of their questionnaires and come for scans, and some of them were my patients and others were, other patients in CABs. And so I'm very grateful for that. And then our BD Long small team is listed here. The larger team is shown in the picture. And I want to acknowledge my amazing research coordinator who really made this possible, Jamie Feldman, and my funding sources. All right, thank you.
We definitely have time for a few questions. Anyone from the audience to start? Do we have any online? Or Manpreet?
So I love this focus now in intra-individual variation, and I'm curious to know if you think this would lead to more heterogeneity than construct validation but underlying pathology.
Yeah, so right. I mean, that question about whether the variation is actually going to lead to more heterogeneity than a defining. So I actually think that concept that the signal could be in the noise, and that there may be a lot of variability in networks that we're interested in, and that variability might map on to even the propensity for mood disorders, might be another construct. I think it's different from a lot of the things and regions that you and I are both interested in, like left VLPFC, that really may be more sort of trait-based in that way all the time. So I think it's a different lens for looking at it. One thing I just like about this is that all of our brains are so different, and there's just so much heterogeneity. But if most people with most healthy controls, or most people without bipolar disorder do have that sort of stability, then that becomes like something that we can really use more as a test. So the short answer is I don't know. And yeah, I mean, looking at variability is complicated for all sorts of different reasons, but I think it also really does map on to what we know are the defining characteristics of bipolar disorder.
Yeah, you mentioned that you used to scan them almost every week.
Oh, sorry, not scan them almost every week. I didn't have the money for that. No, did I say that? If I did, that was incorrect. What I meant is that they had to fill out questionnaires every week about their mood. And then if their mood had changed, we did an interview, we did the A-Life to figure out, and Weimars and Madras to figure out if they were in a new mood state.
Yeah.
And so we scanned them 4 to 6 times, not every
So
week.
questionnaires were based on the symptoms and the states, like they were closed at questions.
Yeah, so the questions that we sent them every week was the PHQ-9 to assess depression, and then the Altman scale, which has its issues, but to sort of get at some hint of mania. And then we also asked them, do you think your mood has changed in the past week? Like, are you in a new episode? And so that was sort of how we said, okay, then we need to, like, you know, bring them in. We didn't bring, we talked to them over video chat to see, then do the more extensive interviews to see if they were in a new mood state.
Do we have any online questions? No? Okay, thank you.
All right, thanks so much.
Okay, so our next speaker of the afternoon is Dr. Jess Fiedorowicz, who is the head and chief of the Department of Mental Health at the Ottawa Hospital and a professor and senior research chair in adult psychiatry in the Department of Psychiatry at the University of Ottawa. Outside of his roles in Ottawa, Dr. Fiedorowicz also serves as the editor-in-chief of the Journal of Psychosomatic Research and is also a member of the U.S. Food and Drug Administration's Psychopharmacologic Drugs Advisory Committee. His expertise centers around morbidity and mortality, in particular cardiovascular disease and suicide and bipolar disorder. So welcome, Dr. Fiedorowicz.
Great. Thanks so much for inviting me here. What a terrific conference. I love this size group too. It really, I think, facilitates networking. This talk is going to carry forward from some of the things we heard this morning about risk calculators, including going further and validating the risk calculator that Dr. Goldstein presented earlier. For disclosures, I don't have any financial relationships disclosed. This study was funded. This was funded through the COBE study from NIMH, and I guess even before that, the original data from a much older NIMH study that I'll be talking to you about soon. The study team is listed on there, so thanks to all the members of the COBE study for pulling me in to externally validate this risk calculator. So many of you, especially with medical backgrounds, may know that risk calculators are commonly used outside of psychiatry, especially in cardiovascular disease, but also in cancer, where it's a little less familiar for me. But so for instance, with cardiovascular disease, we determine whether or not to start a statin based on what someone's 10-year cardiovascular risk is. And so we're ultimately making decisions on that. We don't do that so much in psychiatry yet, but I think there's the hope that we can, better personalize our treatments, identifying higher risk groups by taking sort of a more quantitative and deliberate approach to things. And as you saw earlier this morning, Dr. Goldstein had developed a risk calculator from the COBE data to look at 1-year risk of suicide. And I'll talk a little bit about how that calculator is developed, but we sought to externally validate that in really a quite different sample. And I think the results are striking and hope you do too. These are the variables that went into the risk calculator. A few important things that I want to talk about. So the one thing that's worth noting is that they didn't identify the items from a search of the own COBE data, and the risk of that is any that something that's overfit and then might not survive an external validation. But these were taken from the broader literature, and then those that performed best were chosen. And so these are the 10 variables that were used for that risk calculator. There are a couple of other published suicide risk calculators, but those use the prominent ones use 17 and 23 variables respectively, which, as you could imagine, might be quite onerous for a family doctor for sure, and probably a psychiatrist as well, even with more time. And so I think it's also important that these are variables that are clinically accessible, that you could get in your practice so that you might have access to, and that you don't need to book a half-an-hour break to plug into some sort of computer. This was the risk calculator from the Dr. Goldstein study, so AUC of 0.82, which is slightly better actually than the ones that are used in cardiovascular practice, and that's in spite of having a 1-year time frame instead of a 10-year time frame. So we could, have things perform better by saying we're going to be looking even longer term. And this was developed for those followed at least 2 years from that sample. Half the sample was used to train this, and the other half was used to test this. And so this AUC comes from the test data. And then we have the demographics of the sample here. So a slight majority bipolar 1, and then next being an unspecified bipolar disorder, and then a small group with type 2. So the external validation cohort is going to look quite different than the COBE data set in a lot of ways. And so if this is a negative study, we could explain that away by some of the many differences. I'll clue you in that it's actually not, that we essentially externally validate this in spite of things being so different. So these folks were recruited between 1978 and 1981. This is the data set that I sort of cut my teeth on as a junior researcher. This data is collected on paper cards, for any of you that know what those are, where they actually have punch cards where they're storing the data because they didn't have external disks like floppies yet to be able to store the data on. And so the data is all in quite an interesting format. 5 academic medical centers in the US recruited these people. This is a pretty, this is a high severity sample. So these folks, 3/4 of them were inpatients actually at the time of recruitment. And so even though this is a later age of onset sample, as you'll see, it's not necessarily a lower acuity sample as you might otherwise expect from later age of onset. We looked at the 427 people that had prospective diagnosis of bipolar 1 or 2. So we heard earlier today, right, that many people that have major depression, that may not be the correct ultimate diagnosis, but we haven't followed them long enough to see how the disease is going to manifest itself. So we took those that had developed mania or hypomania at any point, and a decent number of those were major depression at intake, in fact. And I think this is so amazing. The sample was followed for a median of 22 years. So we have a large sample that was followed for a long time, very well classified from a time where they took inter-rater reliability even more seriously, I think, than we do today. Age at intake, 3 times as old. This is also an older period, right? This you know, much of the follow-up is in the 1980s and 1990s with some follow-up past 2000. Similar SES looking, similar bipolar 1, but more bipolar 2 than unspecified. And I think another thing to note is that there is a lower family history of suicide attempt, and I want to explain that a little bit in the coming slides. We'll see that we don't ascertain it as well. And so the collaborative depression study focused on first-degree relatives, and the only second-degree relatives that were assessed were half siblings. And where in the COBE data, we have a rigorous assessment of second-degree relatives as well. And so I think that's likely the main reason for that under ascertainment. Follow-up is similar, is long as well. And we also have lower MSSI, and this is also sort of a data capture issue. And so non-suicidal self-injury was not assessed at baseline, with the exception of that the lowest rated, what were called suicide attempts on that scale today would not be called suicide attempts because they were no intent. Where now we consider there to be at least some ambivalent intent to consider an attempt. And so if their most severe attempt at baseline was no intent, then we could capture it. But otherwise, if they had a more severe attempt and they also had non-suicidal self-injury, we would miss that. But over follow-up, we are able to classify it based on that same measure. So what we have from the 10 original variables is all but 1 and 2 where we have really incomplete ascertainment of. And so we have 7 solid, and then another 2 that are okay but not as strong. Essentially what was done with this data is applying the risk calculator every year of follow-up. And so if someone was followed, if one participant was followed for 10 years, we'd look at the baseline 1 year, 2 year, 3 year, 4 year, look at the variables that were relevant for that time point. So they were time varying variables. So if someone had no prior suicide attempt at intake, but had a suicide attempt at year 5, then all the ones past that would recognize that. And then we made predictions to compare what was estimated for the risk, and then whether or not we observed an event during that 1 year period. And I think the 1 year period is also important because a number of other studies that look at risk look at it over a much longer period, where here this is a defined timeline that might be relevant for an intervention, such as, for instance, a 1 year trial of DBT, for example. And here's how they compared, and I think they're actually strikingly similar in spite of the differences in the sample and the fact that not all the data was there. The area under the curve of about 0.78, which is about at or slightly better, depending on the type of study you look at for that's currently used for cardiovascular disease. As far as calibration goes, it's reasonable. So that diagonal line essentially would be where the observed risk is matching the predicted risk. And you'll see here that it follows it except for the highest risk group, where the risk calculator is actually systematically under assessing risk in this sample. And these analyses are to test the robustness of the model. So I mentioned the model can be done without all of the data present. And so this shows what would happen if in this data set, if one of those was pulled out, how much of an impact would it have on the area under the curve. And you can see for most of them that the model is pretty robust, and it's still reasonable for depressive episode severity, but that is the one variable that if it's missing, that you're going to see a substantive decrement in the performance of the model. So we'd be looking at essentially dropping from an area under the curve of say 0.78 to 0.68. So one that you'd want to have. You may recall that this group was not only older, but they were older at age of onset. And you might wonder why it was such a severe group, but again, they were recruited inpatients. So they might be, more events than you might have expected from a group with this age of onset that was more representative of a broader clinical population. But we stratified the analyses to look at the early age of onset versus the later age of onset, just to see if the calculator performed better or worse under those circumstances. And it indeed performed slightly better in those with an early age of onset, which is the group that better matches the sample from which this was derived. So to summarize the findings, we indeed externally validated Dr. Goldstein's suicide risk calculator in a much older sample with mood disorders and using 9 of the 10 variables and 7 of them solidly. The performance was within the accuracy of risk calculators that are actively used in cardiovascular medicine. Some underestimation for the high risk group. Although again, I think if we talk about like what we're using this for, like if we're trying to calculate what the actual risk is, we might be underestimating. If we're trying to identify a high risk subgroup in some way, the calculator is still going to perform reasonably well. And then slightly better performance with those with early age of onset. And I think it's really noteworthy that this was done again in spite of an older data set, older patients, different timeline, different treatments that were around at the time, and then not identical information available. So talk about risk calculators in psychiatry, and so there's been several that have been developed for various areas. Although I would argue that none of these are in routine use. There may be some use, some sort of niche use of risk calculators for developing onset of psychosis. But otherwise not as present. The risk of mood recurrence one at the bottom is one that was also developed in the COBE data set and was externally validated in the CDS. So this represents the second project of this sort of COBE CDS alliance for developing risk calculators. And so what might this be used for? And so one thing that the clinician in the audience or clinician might immediately think of, okay, one of the big clinical decisions that I may have to make is if I'm in the emergency room and I'm seeing someone who's acutely ill, do I need to admit this person or not? That level of risk, I think, remains quite difficult to assess. And so, this 1 day or 1 week risk that you might be intervening there. But a 1 year risk, I would argue, is clinically relevant for a number of decisions that might need to be made or a number of things people might need to do. So, I was talking with some American colleagues about how there are limitations in access to mental health care in both the US and Canada. So we have, for instance, at my hospital, we have Working with Emotions and the DBT Light or DBT Informed sort of group. And we have a wait list for both of these groups. And so if we're trying to intervene to reduce suicide risk for one of them, can we identify those at greatest risk to prioritize them for the group, and so that we can get sort of the most bang for our buck, for example. And if we're doing an intervention for some sort of suicide group, if we have funds for case management or intensive case management, who are we going to target to? I think this does give us a reasonable chance to do it. Now, we might be overestimating risk in the high end, but we can, I think, certainly pretty reasonably identify a high risk group, and as reasonably as we can for heart disease, where doctors do this all the time without thinking about it. I would argue this might also facilitate research as well. So we talked earlier about the understudying of suicide in research and how a number of clinical samples that are used in research exclude those. I think that time needs to end, and we need to start studying higher risk groups. And if we're going to study higher risk groups to power our samples, we need to make sure that we're indeed enrolling those at risk, or we're not going to be able to see differences in outcomes. And I think this is the sort of tool that could be used to identify a higher risk group for some research intervention or research study as well. So I think there's indeed potential here. The variables in it are clinically accessible, so you don't need to do laboratory testing, don't need to do invasive, brain imaging, or not that brain imaging is invasive, but like expensive or invasive studies to do that. So anyhow, so I think there's potential here for use in personalized medicine, and excited to have the opportunity to present it, and especially even just to follow Tina in the presentation where you guys got a snippet of the calculator to begin with. And so I'm happy to take any questions. Yes.
Hey, Jess, I know this was the focus of this was on external validation. But
Yeah.
it's sort of more of a meta question for you. Do you think that there's something different about earlier age onset as an independent risk factor? Are there neurobiological, explanations for that?
I can't dive into the neurobio, but I can definitely sort of touch on the epi side. And I think there's very good reason to think that the early risk subtype is at higher risk of a variety of outcomes, and sort of is indeed a sort of a different phenotype. Where you define early risk, I think it's really challenging. For a different paper, I'm trying to remember. No, it was for the. We did this stratification by early onset for the previous risk calculator paper. And so then I went into trying to figure out, like, well, how do we define early onset? And went and looked at studies. And well, a number of studies do it differently, but there are these studies that do what's something called admixture analysis, where they essentially look at the distribution of age of onset and then try to do sort of mathematical modeling to see sort of what sort of clusters might come up. And those get sort of varying results, but all of them essentially seem to show this sort of this sort of earlier onset subgroup. And in all of those studies, that subgroup looks differently enough that I think that that's reasonable, think it's valid. It's just how do we best define it? And the neurobiology piece, I'll defer to those that have more neuroscience savvy than I do.
I just wondered comment on this data suicide risk think that some of these tests that really got
Yeah, that's a good question. I'll start with it, and then if Tina has more that she wants to run with it, I think we may want to invite her to join in. So the disease, I don't know if the disease-specific thing helps, but it's a fantastic question. So the two other risk calculators I alluded to, one is called it's like OMXIS, and it was developed from administrative data in Sweden. That's the one that used the 17-item measure. It didn't perform as well. I don't know if it didn't perform as well because it was saddled with administrative data, or if it didn't perform as well given this disease specificity piece here, right? Because we have two samples that are clearly bipolar disorder. The other major one that I'm aware of, and Tina may be aware of more, is a Durham risk score, which is 23 items. They're all sort of like dichotomized. They are sort of clinically accessible as well. It is not disease specific, and it is performed well and better than this risk calculator. But again, it's fairly lengthy, and so I would be interesting, but we didn't have the data in this data set to look, but it might be interesting to compare them head to head in the same data set. I suspect they might have different utility. But great question. And there's also reason to think that the specificity may be important because, as we know from the earlier talks, that the risk of suicide and bipolar disorder is especially high and striking. So, I don't, Tina, do you have anything you want to add to that? Or?
And there are, suicidal behavior is so multifactorial, and that there are unique risk factors among people. And so, in that sense, and that there are some differences among earlier onset. And so, in that sense, I think it's a very reasonable hypothesis that you would keep it's a great empirical question, but I think theoretically it makes a lot of sense by that.
I'm just going back to our variables here. Maybe this list would be better just since the question was related to that. Any online? All right, great. Thanks, everyone.
Our last speaker of our afternoon session is Dr. Vinberg, who is a psychiatrist and professor at the University of Copenhagen, as well as the leader of the Early Multimodular Prevention and Intervention Research Institute, or MPIRI, at the Mental Health Center, Northern Zealand, Copenhagen University Hospital. Research-wise, her goals are to advance understanding of the complex biological, psychological, and environmental interrelations that underlie affective disorders, and to prevent the development and halt the progression of these severe and potentially disabling disorders. So her research bridges the areas of translating psychopathology and neurobiology into clinical settings with a primary focus on the early stages, and it aims to identify clinically relevant risk and resilience factors, including peripheral biomarkers and mood disorders, and to develop new combinations of medical, psychological, and social individualized treatments that target the prevention of onset and recurrence in mood disorders, and thereby improve overall functioning and quality of life. So I'd like to introduce Dr. Vinberg.
Thank you very much for this kind introduction, and thank you for inviting me here. And it has been a privilege to listen to the previous lectures. So I will start with the, it's a small presentation. There I can see it, just to find my way around here. But the title for this presentation is Childhood Maltreatment, and we had looked on the associations between biomarkers in young patients with bipolar disorder and their unaffected relatives and control persons. This has been done together with my group in Copenhagen with Lars Vedel-Kessing and Camilla Miskowiak and Maria Fagerholt, and also our postdoc Clara Coelho. And we all know that rich and secure environment for the development of children would be nice, and all over in Toronto, and here it says that you need to be good to the children. So, but even though you can see that physical impact of trauma, I tried to illustrate it, it will influence all, both on cellular level, all kind of levels in the body. And oh, sorry, yes. And therefore it's of interest to look at how child maltreatment might influence our biomarkers in adulthood, to get some answers here. This is my disclosures. And to look at the biomarker of interest, we have been looking at these biomarkers in several cohorts: oxidative stress, neurotrophins, inflammation, and metabolomics and cortisol. We haven't looked at the cortisol axis in the present sample, but we have looked at neurotrophins, and all the results was negative using BDNF. So I won't mention them anymore. But if you want to link environmental stress and biomarkers, we have done this because we know that childhood maltreatment is an established risk factor for onset bipolar disorder, and we also know that inflammatory and metabolomic markers are associated with BD. And just to explain that oxidative stress is a marker for an imbalance between the oxidants and antioxidants in the cells, and it's illustrated by the apple, that if the repair mechanisms is slower than the new oxidative stress, the cell would start to shrinken, and it's associated with aging, and also associated with the possible explanation that patients with bipolar disorder lives fewer years than the background population. We have measured these in urine using two substances, 8-oxygu, the DG, and 8-oxygu, that are markers for DNA and RNA damage respectively. And for that, we have the bipolar illness onset study. It's a study that we have conducted in the catchment area of Copenhagen. It's around 1 million people. And we have a specialized clinic where we have invited all our new patients. It's an outpatient clinic. We will receive patients when they have their onset of bipolar disorder, their first diagnosis. And we had included around 800 participants in total, where half of them are patients with bipolar disorder. We have they have allowed us to contact their unaffected relatives. And finally, we had the healthy control persons from the blood donors at the hospital. And these patients and the relatives and healthy controls have been assessed very thoroughly. We have all of them have been interviewed diagnostic. We have assessed the depressive and manic symptoms. We have assessed their clinical course, their smoking habits, their shoe number. We have everything on. They've been scanned, and then I will measure 2 of the questionnaires we have used. We've used the Pittsburgh Quality Index, and we have used childhood trauma questionnaire. That is the main questionnaire in this investigation, where we had looked at, and childhood trauma questionnaire looked at 5 items. They're measuring physical, sexual, and emotional abuse, and physical and emotional neglect. And it is validated into and translated into Danish. This is results, previous results, published results. The present data today is unpublished, but we have looked at oxidative stress and metabolomics in the whole cohort, where we have seen that both metabolic syndrome and oxidative stress are more higher and more often in patients with newly diagnosed bipolar disorder. And we also found that the patient who had more oxidative damage, both to their DNA and RNA, was associated with a higher cardiovascular risk score, higher degree of insulin resistance, and an experience of more childhood maltreatment. But we found no significant associations with the high sensitive C-reactive protein. So, looking at based on these questions, it would be of interest to look at the young participants in our cohort. As you just said, that the methods we're using standardized operation procedures. So all the patients will be fasting, they will come in the morning, and all the processing is done by blinded laboratory personnel. So this is a busy slide. I will try to walk you through it, but we have here in total 265 participants who are at the age from 16 to 25. And there's the patients with bipolar disorders is the most represented. And if you look at their age, they have the same age, it's around 22 years old. The healthy control persons are better educated. There's more men in the among the unaffected relatives. We see a higher body mass index in both bipolar patients and their relatives. And the patients and their relatives smoke more often. Actually, it's quite high. 50% almost of the patients smoked compared to 15% in the background population. And of course, they had higher levels of affective symptoms. And looking at PCQI, the quality of sleep, they had quite high scores, the patient group. And if you're above 5, you are at risk. And then finally, that looking at childhood trauma questionnaire, the bipolar patient had higher scores, but also the unaffected relatives. But they are interconnected because they have the same families. And looking at the biomarkers, I have this slide to walk you through, looking at DNA damage and RNA damage, and also this CRP and the triglyceride. They're all higher in the affected group, the bipolar patients, and almost lowest in the control persons. Then we had used the multiple regression models to adjust for they adjust for age, and gender, and smoking, and alcohol, and the body mass index. And still after adjusting, we saw that the DNA damage and the RNA damage was significantly higher in the individuals who had reported more childhood maltreatment. We also saw that the young patients with bipolar disorder had a higher levels of inflammatory and metabolic markers, but they were not associated with childhood maltreatment. When looking into the three groups, it was the patient with bipolar disorder that was the main driver of the differences of the higher DNA and RNA damage. And the RNA levels, damage levels, were associated with more childhood maltreatment, also when adjusted for all these variables, smoking, alcohol, and body mass index. And when we looked into the childhood trauma questionnaire, it's of interest what kind of trauma is the most severe, and it's emotional neglect and almost statistically significant also physical neglect that contributed most to the enhanced damage to the nucleus. And then we had some sensitivity analysis where we were looking at the damage, and it was driven by symptoms. So the patient that was not in full remission had the high levels, poor sleep quality, and also more healthy, not surprisingly, smoking and more unhealthy lifestyle. And to put these things into a framework, I always like this model by Casper and Moffitt, where they said, how could these options of a bad environment interaction act? And we all know that we can have a linear relationship between genes and disorder, or it can be through endophenotypes. So we have the disorder, or you can identify the genes for disease using the endophenotype. But the last solution, I think it's best fit for our results, is to say that the information about the environment is incorporated. So you first have the environment that kind of influence the genotype, and then changes in our substrate reactivity, and finally you can develop the disorder. And the question is whether this is reversible. It would be a good thing to show, then you can be more direct with the prevention. So in conclusion, our study, the preliminary results revealed an association between childhood maltreatment and the oxidative damage to DNA and RNA. And it also suggests that childhood maltreatment, especially emotional neglect, would contribute to an enhanced systematical oxidative damage even in early adulthood. And finally, the young patients with the bipolar disorder reported that they had experienced more childhood maltreatment, which may induce these higher levels of oxidative stress. And the discussion can then be, is it directly or is it indirectly? Will you change your HbA axis, for example, or is it because they start smoking early, have a risky behavior afterwards? So it's a good discussion, I think, but it can possibly lead to the increased risk of new episodes and a poor course of the disorder, and we need these longitudinal studies to clarify the relationship. And the perspectives is that I think that we should all realize that these maltreatment or severe life events is capable of leaving a lifelong biological trace that can impact and increase the vulnerability both to onset but also to new episodes. And as it is a risk factor, it will outline the need for preventive care. And I think that a routine mapping of difficult life events in our patient and also in our at-risk patients, possible patients, can contribute significant clinically. And we have looked at that in the whole cohort of over 800 participants. And if you separate the 500 patients with bipolar disorder, you can see the ones who had more than 2 or 3 severe life events, they were later diagnosed. So their time to delay was 4 to 5 years more than the other group. They had more suicide attempts, a lot more suicide attempts. It's a serious complication. And they also had more admissions, previous admissions. So I think we could use this both in terms of assessment, the diagnosis, and to pinpoint out treatment. Oops.
I don't know if you've heard about the recent fascination with ketogenic diets for bipolar disorder.
Yes, I heard a lot.
Comment a little bit about their potential value. You know, what do you think? Do you think that it's going to be a great? Should we be giving people antioxidants?
Yeah, I'm not sure whether ketogenic diet is an antioxidant diet, is it that?
Yeah, it's a good question. I mean, that's part of its sort of proposed charm for some people. I think that we need more randomized controlled trials to understand its potential benefit, either as a preventative target or more adjunctive. But I just find it so interesting that could it be possible that early dietary modification could be of use to youth in a preventive way? Nutrition certainly can.
I think.
You know, does it prevent maltreatment? I'm not sure, but I am curious about sort of the intersection around, especially mechanisms that engage oxidative stress.
I think there's a potential here, and I think it would be quite interesting to combine it with microbiomics to look at this together. We have microbiomic part of these participants, but still I also think that the best evidence is for Mediterranean diet. So I think coming into young and to children, I would be very careful to prescribe a ketogenic diet with the pros and cons it has. But it's a very fat diet as well. And I think we have the experiment that half of the population in some of the Western countries are very fat, and we also have increasing rates of depression all the time. So it might be, I'm not saying that this is, but I think we should be careful about prescribing a fat diet. No, thank you.
Okay, so that concludes our first rapid presentation session. So we're gonna break quickly for just a stretch, or you can check out the posters in the lobby, and then we'll reconvene in here at 3:10 for the next series of presentations. So thank you.